Is Dr. Vivek Anand or Dr. Kumar Prabhash or Dr. Santoshi Nagaonkar anyone in the hall? Dr. Vivek Anand, Dr. Kumar Prabhash or Dr. Santoshi Nagaonkar? Okay. A very good afternoon, ladies and gentlemen. Welcome back after the delicious lunch. Our next session is about debates. It is debatable whether it will keep your post-prandial slumber away or not. I'm sure it will. While we are waiting for our chairpersons to arrive, may I request Dr. N.P. Gupta to please chair the session till the others join in. Dr. Gupta is a Professor Emeritus from Medanta Medicity, Gurgaon. Dr. Vivek Anand, who will join us shortly, is a consultant radiation oncologist, PD, Hinduja Hospital and Research Center. Dr. Kumar Prabhash is professor and head of the Department of Medical Oncology, TMH, Mumbai. And Dr. Santoshi Nagaonkar is the director, Department of Urology, Uro-Oncology and Robotic Surgery at Sir H.N. Reliance Foundation Hospital, Mumbai. Before I hand over the session, may I inform the participants and chairpersons about the time allocations. It is 7 minutes per speaker, followed by 6 minutes for discussion. If you exceed the time limit, it eats on to the discussion time. I will be strict in maintaining the time. No rebuttals. And to conclude, the chairpersons can take the mandate of the House or give their expert opinions and remarks. Please adhere to the time allotted. And if speakers exceed the time limit, I will be ringing my bell. Please respond to that. So we have the first debate, which is doublet versus triplet for MCS-PC, quantum of benefit with an eye on complications. For doublet, I invite Dr. Alison Tree. She's a consultant clinical oncologist from Royal Marsden Hospital, London. Over to you, to Dr. Alison.
Thank you very much. It's a great honour to be with you today, and I bring greetings to all of you from the Royal Marsden Hospital in London. Here are my conflicts of interest. So to frame this discussion, it is inherent on all of us, as Hippocrates said, the father of Greek medicine, that we should first do no harm. So we have to be sure that any treatment we recommend for a patient has more benefits than it has costs. Now in England, we like to eat a lot of toast. And this is toast pictured with Heinz beans, which is something... You got my slide? Ah, okay. Shall I wait for my slides to come up? Aha, there we go. So in England, we like to eat some toast, which is grilled sliced bread, and it's often, you put beans on it, particularly for children. It's a nice savoury dish, tomato-flavoured beans, very nice. But we also like to have toast with sweet jam and lots of creamy butter, and this is also delicious. But you wouldn't necessarily think of putting the two together. In fact, that would be quite disgusting. So two things that are nice on their own don't necessarily make a better thing if you put them together. So what is the standard arm for newly diagnosed men with a hormone-sensitive metastatic prostate cancer? Well, in my opinion, I would say the standard of care now is hormone therapy, androgen deprivation, with an androgen receptor targeted agent, or ARTA for short. What does the NCCN say? Well, they list a variety of options. Triplet is one of them, but the first option is ADT with AR targeted agent, or ARTA. And what is not listed as a standard of care any longer by the NCCN is ADT and docetaxel, not considered at all. So why are we even talking about triplets? Well, this is an artifact, a mistake, an accident in timing. These 3 trials will set out to demonstrate the benefit of AR-targeted agents. And while the trials were being carried out, Stampede reported that docetaxel, in addition to ADT, became the standard of care. And so all 3 trials changed to allow docetaxel in combination with AR-targeted agents. Piece 1 was a large trial, over 1,000 patients. It was a complicated trial to start with 4 arms, and it became more complicated with 8 arms by the end because some of the patients received chemo and some didn't. And what it showed overall was that the addition of abiraterone improved outcomes for this population within and without the patients with docetaxel. So is this evidence that adding docetaxel to ADT plus ARTA improves outcomes? Absolutely not. What about Enzamet? Similar trial. The objective of the trial was to demonstrate the benefit of AR-targeted agents, which it did. It showed that if you add in enzalutamide, you keep your patients alive for longer. And some of these patients also received docetaxel. Is this evidence that adding docetaxel to ARTA therapy improves outcomes? Absolutely not. That's not the question being asked. And then thirdly, the Arasens trial, similar design again, but this time with darolutamide, another AR-targeted agent. And once again, showing a big benefit from the addition of AR-targeted agents, whether or not you had docetaxel. So is this evidence that adding docetaxel to ARTA improves outcomes? No, that's not the question being asked. But you might say this is a young patient, so he's got lots of disease. What harm can it do to add in docetaxel? Well, I can tell you it can do quite a lot of harm. So this is data from the Stampede trial, a group of men recruited contemporaneously. Some of them received abiraterone and some received docetaxel in a randomized fashion. And this is the global quality of life score in blue for the men receiving docetaxel and in red for the men receiving, in this case, abiraterone as their ARTA of choice. And you can see a significant detriment in quality of life which persists out to 9 months after chemo, so well beyond when the chemo has finished. And this has been reflected in Enzamet, one of the trials I just showed you, that the quality of life detriment of these drugs is additive. So they get a hit from their enzalutamide and they get another hit from the docetaxel. And the patient we were asked to consider in this debate was a 64-year-old with diabetes. We know that diabetes increases the risk of significant side effects from docetaxel, so he has more to lose than most men. So what do we do with this data? Because no one's actually answered the question that we were asked in this debate. Well, there's been 2 interesting publications in the last couple of months, both all collaborating all of these trials together. So this is the first one, a network meta-analysis, 10 randomized trials, over 11,000 men. And what they showed was that there was an improvement in overall survival to adding an ARTA, an AR-targeted agent, to a standard of ADT and docetaxel, but no significant improvement in overall survival from adding docetaxel to any of the AR-targeted agents. There was a small improvement in progression-free survival if your baseline was abiraterone, but not in the presence of enzalutamide or darolutamide. And the second paper, similar thing, but restricted mean survival time as a way of pegging the trials together. Lots of these very large randomized trials. And the message of this slide is that actually if you put all of the data together, the group that does worse is the ones that have ADT and docetaxel. The next worst is the triplet therapy, and actually the doublet therapy seems to have the best overall survival of all when you look across trials. So in conclusion, this data shows that no trial has proven an overall survival advantage for the addition of docetaxel to ARTA. ARTA we know is better tolerated than docetaxel with less impact on quality of life, and therefore we shouldn't mix beans with jam. Thanks very much.
May I have the mic, please? For triplet, we have Dr. Vashisht Maniar, who is a founder, director, and consultant medical oncologist at Mumbai Oncocare Center, Mumbai. Over to you, Dr. Maniar.
Thank you so much. Can I have my slides, please? I hope by the end of this talk, I can convince that it's the cheese and not jam on our toast. Thank you so much. Right. Can I get my slides? Perfect. So, who's the patient that we wish to help today? He's a 64-year-old male. He's a well-controlled diabetic. He's a de novo prostate cancer, and he has a high-volume metastatic disease using PSMA-PET. That's the basic information that I had been given before I made my talk. Is it for all comers? The answer is definitely no. What do we wish for our advanced cancer patients? We want them to live longer. We would want to delay progression and hopefully make them live better as well. We know that most patients will eventually die of disease itself, and castration resistance is associated with a poorer quality of life. So if one is metastatic yet hormone sensitive, we wish to delay the onset of castrate resistance and hopefully make them live longer. How do we define these patients? Data that probably I don't need to discuss in front of an august audience, but important to understand what is high volume and low volume based on the chartered and the high risk and the low risk definition based on the latitude and Stampede data. Here we are talking about a patient who has a high volume disease, meaning more than 4 bone metastasis plus minus visceral metastasis, or a high Gleason score. Yes, a lot of accidents have happened in the entire journey of oncology, but these accidents have probably made us wiser. Sometimes a trial is not intended and powered to answer a question, but it definitely does open up our minds towards what is the next best therapy. So 10 years back, the standard of care was just giving them ADT, and in the last 10 years, we've now discussing a triplet, forget a monotherapy, which may potentially become standard of care. Doublet therapy better than monotherapy? I think we have enough evidence to believe so. But then, what is the unmet need, and why am I even talking here? Because most patients would still become castrate resistant on an average of 3 years. High risk, high volume patients, probably even earlier, and hence there is potentially a rationalization for intensification of triplet, hopefully with the adage of hit early and hit hard. The studies with the combination of this triplet, we probably all know Enzamet, PIS1, and Arescence, and I'll be the first one to admit that that was not the reason this study was made. It was not made or intended to find out whether triplet is better. While previous therapies have 6 arms or 8 arms, as Professor mentioned, let's not forget the current standard of care, which is Latitude or Stampede. Stampede had 12 arms, and we embraced them because it gave us so much more information. So what did the Enzamet tell us? The Enzamet told us that the people who did receive docetaxel did not seem to have a significant OS benefit, and 60% of these patients were high volume. Again, not the intention with which the study was done. And 10% of these patients could not actually finish the triplet versus 75%. So probably one believed when the data of Enzamet came that this may be the end of it all. But then PIS1 changed what we thought was where we could have at best reached when it came to a metastatic HSPC and be happy with a doublet. It had an arm which gave doublet. Again, it was not prospectively designed to investigate this question whether triplet is better, because the SOC has been changing in the last 10 years. 2013, we were looking at ADT alone, and then came the Stampede data, which told us, you know what, docetaxel should be permitted as standard of care. 2017, they made it mandatory because it was the standard routine practice to give them docetaxel-based combination of chemotherapy. What are the patient characteristics in both the arms? Largely similar, but look at this, and I think this is really hard to ignore. If you have 50% patients who remain radiologically progression-free at the end of 4 years, you have 2+ years of extra radiological progression-free survival. I think this is something that we may find it very hard to ignore. In all comers as well, we found that the data was interesting, but what if we tease out the patient that we're talking about today? High volume disease, it's far more. An HR of 0.47, are you sure you would want to ignore? People are talking about RFS, what about OS? Because isn't that the ultimate goal? Yes, we're looking at OS benefit also, a 25% risk reduction, which includes a statistically significant value in terms of people living longer. Again, is this data related to only high volume disease? Probably in low volume disease, I agree it might not be a great addition because you're adding a lot of toxicity, but high volume disease, people are going to become castration resistant sooner. We are probably saving more lives than harming them. What about these patients? 25% is not very interesting and exciting for a large number of people, but let's not forget that most of these patients in the control arm also received subsequent life-prolonging treatments after progression. And in spite of them, if you can get a significantly, statistically important, significant overall survival benefit, hard to ignore. Is the quality of life terribly bad with the triplet? Yes, there is more chances of developing hepatotoxicity, hypertension, but aren't we as medical oncologists quite comfortable dealing with these side effects? The last one was probably designed specifically to define whether a triplet will be better than not. Arescence tried to answer that question, and did it answer it well? I think it did. There's a 13% overall survival benefit, statistically significant, hazard ratios, early suppression of curves, everything for all to see. In terms of toxicity, again, largely manageable. As we all know, most medical oncologists would believe that they are used to managing a taxane-related side effect because they've been dealing with these drugs probably for the rest of their lives. Combining that with ADT, did it dramatically affect their quality of life or outcomes? Most probably not. Interestingly, one of the major caveats of an Arescence is the fact that it did not classify patients into high risk and low risk, but it actually prospectively collected that data. And let's use these high volume and low volume criterias of Charted and Latitude. And are we wiser? Yes, you can see further separation of curves in people who are high risk. If this was not enough, forget overall survival. Our another worry is time to castration resistant, very early separation of curves, which remain separate for a long period of time. The same goes for more so if you are a high-risk patient. If that's not enough evidence, then there is a European Journal of Oncology article which looks at 6,000 patients in 10 plus randomized controlled trials, all comers. Definitely there is a statistically significant survival benefit if you combine all the three. The best is darolutamide docetaxel ADT, the second best is abiraterone, and you can see the other two fall on the other side of the forest plot. So I'm putting now all the data that we have together. And sorry for such a busy slide because I'm kind of heartstrung at 6.5 minutes. You can see on the forest plot, everything is on one side when it comes to survival, when it comes to PFS, and more so when you have a high volume disease. Coming back to our patient today, 64, young, fit male, well-controlled diabetes, de novo prostate cancer, high volume, metastatic disease. Are we justified in probably giving him a therapy which he may be able to tolerate? Most likely. What do we want? Let's come back to the first slide that I made. We want them to live longer, delay progression, and preferably live better too. Thank you. Last and most important slide. Let's not forget the patient. We may debate about a doublet or a triplet, but if this patient deserves a monotherapy, he's 86 years old, please respect and see the patient in front of you before you deep dive into data. Thank you so much.
Thank you.
I hope that was the cheese, madam.
Thank you, Dr. Maniar and Dr. Allison, for definitely keeping my time. We have 6 minutes for discussion now. Dr. Maniar, you can be on top if there is any question to be
Actually,
answered. Would you like to be?
All these, I like to make some comment and then we can pass it on to you all to discuss, because all these studies have been done in European and American patients. Now our Indian population is little bit different from them. So we don't know the side effect, how our patients are going to tolerate. The second most important thing comes to the cost of the treatment, because this debate